Good afternoon, everyone, and welcome to this webinar on scalable value-based payments in Australia. My name is Associate Professor Rebecca Haddock, and I am the Executive Director for Knowledge Exchange at the Australian Healthcare and Hospitals Association, where I lead the work of the Deeble Institute for Health Policy Research. And it's my pleasure to be your host today. Before we get underway, I would first like to acknowledge and pay my respects to the owners of the many lands on which we meet and recognise their continuing connection to land, water and culture. I am currently on the lands of the Ngunnawal people and pay my respects to their elders past, present and emerging. Around the world and here in Australia, health systems are looking to reform the way they fund, organise and pay for healthcare. These changes must ensure that healthcare meets the needs of all patients, their families and carers. They must demand the measurement of outcomes and promote health equity. They must ensure that healthcare is organised around groups of patients with shared needs, and they must drive integrated care delivery. And they must also provide motivation for innovation through data infrastructure and new technologies. The journey towards healthcare funding reform will be long and it will experience some failures. However, a value-based payment system will be an important consideration for creating a sustainable, contemporary Australian healthcare system with an ever-tightening budget constraint. And so it gives me great pleasure today to introduce three eminent health economists who will talk to us about some of those alternate funding models and what they might look like, what the risks, benefits and barriers to their implementation might be. I'd first like to introduce Professor Henry Cutler. Henry is the inaugural Deeble Institute Fellow and joined us at AHHA in 2022, and inaugural Director of Macquarie University Centre for Health Economy at Macquarie Business School, Macquarie University. I'd also like to welcome Professor Kees van Kool. Kees is the Executive Director for the Independent Health and Aged Care Pricing Authority and Deputy Director for the Centre for Health Economics Research and Evaluation at the University of Technology, Sydney. And last but not least, Dr. Michael Wright, Chair of the Central and Eastern Sydney Primary Health Network and Chair of the RACGP Expert Committee on Funding and Health System Reform. So as you can see, we're set for a very stimulating discussion today. And while we have a dedicated chat function, please recognise there are a large number of people online and we won't be able to get round to all the questions, but we will do our best.
Okay, so hopefully everyone can see that. Please jump in, Rebecca, if you can't. So as Rebecca has noted, today I'm going to be talking about value-based payments, and in particular, some research that I undertook in the second half of last year, which was really looking at how do we get from where we are currently in health system reform to a roadmap towards scalable value-based payments. It was research that was funded by the Deeble Institute for Health Policy Research. And I'd also like to acknowledge, if my slides flick over. There we go. I'd also like to acknowledge Rebecca Haddock herself, Professor Jeffrey Braithwaite, Adjunct Professor Michael Pervin, and Elizabeth Koff, who has made contributions to previous drafts of this research paper, which is downloadable on the AHHA website. But all views, of course, presented are of my own. Okay, so we've heard for quite a long time, really, that the Australian healthcare system does have some low-value services. We know that there are potentially avoidable healthcare use and other system waste. It's a problem that's not specific to Australia, and other countries around the world are also dealing with these issues. So, for example, in the US, we know that their GDP, so their healthcare system expenditure to GDP is the largest in the world, and they have a huge expenditure problem there. They're not necessarily getting the value that they want out of that system. They are looking to introduce value-based payments. Well, they have been doing so for the last 10 years, but also to build on that over the next 10 years to arrest their expenditure growth. The UK similarly is looking at integrating publicly funded health and social care to help with their particular issues. We've been relatively slow when it comes to funding reform in Australia. So Medicare has been structurally unchanged really since 1984, and even prior to that, the introduction of Medicare was somewhat tumultuous from Whitlam to Hawke, with Medicare actually being disbanded before Hawke came in. Activity-based funding was introduced nationally in 2012, and that could potentially be considered the biggest impact we've had on system funding since Medicare. But there is obviously a need. So we have a huge debt at the moment, obviously from a response to COVID. But this long-term projection also suggests, and this was done before COVID actually, it's from the 2021 Intergenerational Report, suggests that we have a debt problem that will continue, and we expect that debt problem to be larger than what's presented there, given that impact from COVID. Most of that growth in Australian government debt is from areas within the budget like healthcare system payments and aged care. But there is also a more immediate need. So if we looked at the last MyEFO budget that was handed out by the government last year, we can see that there has been an increase in expenditure, health portfolio expenditure, particularly over the last 3 years. But now the government is seeking to bring that expenditure back somewhat. So if you look in 23-24, you account for not only inflation, but also population growth. You can see the real expenditure growth, which is the grey bar, the light grey or the light tan bar, is around about -8%. And that really shows that we have a pressure on the budget to maintain our spending and to actually reduce spending to bring the budget back into balance. And historically, the government hasn't reallocated funding from other portfolios to portfolios in need. So if you look at the long-term trends over the last 10 to 15 years, portfolio expenditure for health represents around about 16 to 16.5% of total Australian government expenditure. We have a problem that has been identified by Professor Braithwaite as the 60-30-10 problem. 60% of healthcare is delivered in line with guidelines, 30% is waste, duplication, or of low value, and 10% is care that leads to harm. And obviously that's a significant problem when you're looking at a healthcare system that needs more funding to meet increasing needs associated with aging populations and increased prevalence of chronic conditions. Most waste is from overuse of medical services and technology. And if you look at a study that was done a few years ago that matched the way care was delivered to best practice or to guidelines, it was suggested that 57% of adults receive appropriate care across 22 conditions, and that really differed across different types of conditions. So it was only 13% of care that was delivered against guidelines or best practice for alcohol-dependent services, and 90% for coronary artery disease. And similarly, the Australian Commission on Safety and Quality in Healthcare has found that over 330,000 potentially preventable hospitalisations occurred in 2017-18, which suggests that there's potentially a lot of waste within the system. And if we could solve that problem, even in part, we could at least help with some of that waste. There's also massive variation in the delivery of care, and obviously there should be some variation across the healthcare system because there is variation in patient needs. But if you look at some of the variation, and this is in potentially preventable hospitalisations for COPD, we can see that the rate of potentially preventable hospitalisations varies significantly across states and also across metro versus rural and remote regions, to the point where potentially preventable hospitalisations are 18.1 times higher in the highest rate area compared to the lowest rate area. So there's obviously potential for improving care around guidelines and reducing some of that waste that may not be high value care. The issue with waste and expenditure has meant that there's been a much greater focus in the last 10 to 20 years on value-based care. And Porter and Teesberg in 2006 really set the value agenda to improve quality and better manage price and volume through greater competition in the US. And they were really addressing a US problem. But since then, this concept of value-based healthcare has moved beyond the borders of the US into Europe and Australia and Asian countries. But originally, the characteristics of a value-based healthcare system as determined by Porter and Teesberg was one that delivers outcomes that matter to patients. And there were 6 characteristics of that. They were integrating care around specific medical conditions, measuring all costs and outcomes, delivering funding through bundled payments, and we'll talk a little bit about that later, integrating multi-site care delivery systems, expanding geographic reach of centres for excellence, and they really focused also on creating an enabling information technology platform, providing data to allow better decisions to be made. That concept has been imported into Australia, and the New South Wales Ministry of Health is probably leading all states and territories down this value-based care pathway. It has a quadruple aim framework as it defines value-based healthcare, focusing on patient outcomes and experience, provider experience, care effectiveness and efficiency. Within the value-based healthcare framework, they'll be delivering that through 4 interrelated programs: leading better value care, integrated care, commissioning for better value, and collaborative commissioning. And if we just focus on collaborative commissioning, because that will also have outcomes-based payments, it will operate through what they determine as a patient-centered co-commissioning groups, which is comprised of LHDs and PHDNs working together to determine their local needs, but also to potentially co-commissioning services. Now, here's an example of a conceptual diagram of the New South Wales collaborative commissioning process. You can see that the government really sits on the top. Within the middle, you have this patient-centered co-commissioning group comprising of LHDs and PHNs, which determine care pathways, support services, undertake commissioning. But on the right-hand side, you'll also see some of the enablers that have been identified by New South Wales Health, particularly state and federal and partnership agreements. But you've also got establishing funding, so funding that goes to these PHNs and LHDs to help build their capacity to commission and to plan, activity funding, and also outcomes funding. And then on the right-hand side, New South Wales Health have identified some enablers, which are data analytics, implementation support, quality and safety programs, and business analytics. And some of those really speak to the need for improved data collection to identify not only what's required within the community, but also how to transition to those other services. There is a growing appetite for funding reform within Australia. The Medicare Benefit Schedule Review suggested that the recent focus on Medicare has an impact on medical expenditures, the volume care of average fees charged. But the review task force did recommend the MBS be complemented with alternative funding models to improve health outcomes, in particular those that focus on chronic conditions. IHACPA also seeks to increase value through its value-based pricing of public hospitals. They've recently placed a 0 price on an episode of care with a sentinel event and reduced prices for hospital-acquired complications. And they also continue to explore potential conditions where bundled payments may suit. Of course, we have the addendum to the National Health Reform Agreement, which basically outlined this shift in reform between states and territories and federal government towards value-based payments or paying for value and outcomes. And we can see here that within that National Health Reform Agreement, which was agreed by all states and territories with the federal government, we have a nationally cohesive health technology assessment process and paying for value and outcomes, which directly relate to improving value in the delivery of care. We also have identified enablers, similarly enhanced data collection, joint planning and funding at the local level, that very much aligns with what New South Wales Health are already doing, but also enablers for better population health, so prevention and wellbeing activities, but also empowering people through health literacy. And when we're talking about value-based healthcare, we should also be talking about, well, how do we get people to choose better value healthcare? Okay, so now moving on to how do we embed value into funding? So what are value-based payments? So value-based payments are really payment models that use financial incentives to extrinsically motivate providers to align their service towards achieving some predetermined outcome. And so that outcome may be, for example, improving health outcomes, or it may be reducing costs. There is some literature to suggest that financial incentives may complement or devalue intrinsic motivations. And so we need to make sure that if you are introducing a financial incentive, we're not removing some other incentive that was intrinsically within that care pathway. But the value-based payment itself really depends on how value is defined. So if we look at the Porter and Teesberg model, value would be defined around outcomes relative to costs. And the way that they define outcomes is through capability, comfort, and calm. Whereas if we looked at the New South Wales Health definition of value, it's that quadruple aim framework that I mentioned prior. In Australia, healthcare providers are primarily funded through three model types: historical block funding, i.e. Aboriginal community-controlled health services; fee-for-service, which is obviously Medicare and activity-based funding, public hospitals. But they're somewhat misaligned with the purpose and objectives of value-based healthcare. So they don't incentivize better health outcomes. For example, if you were to be paid through Medicare, you'll be paid regardless of those outcomes achieved. And only activity-based funding really incentivizes cost reduction, although that's somewhat muted because, because states still have an opportunity to pay hospitals more or less than the activity-based price. If we go into a little more detail around the characteristics of these mainstream funding models, we can see the differences in incentives that these models introduce. So if we look at the model here, which is not value-based, cost reimbursement, historical block payments, fee-for-service and activity-based funding, which I've mentioned. And on the right-hand side, we have potential incentives. You can see that cost reimbursement, historical block payments, and fee-for-service don't really incentivize improvements in quality or a reduction in unit costs. They do incentivize, fee-for-service does incentivize patient volume because the more patients you treat, the more you get. And it does incentivize the per patient service volume, i.e. increasing the number of services per patient because it leads to greater revenue. Excuse me. If we then move on to some of the characteristics of value-based payment models, and we can sort of classify these value-based payments models as the first generation models, pay for performance and capitation. You can see that again, the potential incentive structures change. So pay for performance, really you can structure it however you want, but it has the opportunity of incentivizing quality improvements, decreasing unit costs, either decreasing or increasing patient volume. So you may, in some instances, want patient volume to be increased if you don't feel as though there's enough access to care, for example, and similarly with per patient service volume. Capitation in itself, so there's three different types. You can have capitation around a specific condition. You can have capitation around all health conditions. So a provider may take on the responsibility of managing an individual's health rather than just one component of that health, i.e. diabetes. Or you could have what's called a capitation population model where a provider is responsible for managing the health of a predefined geographic population, for example. But you can see again that the incentive structures do change across capitation compared to pay for performance. And then if we move on to what could be considered the second generation of value-based payment models, which is effectively bundled payments and accountable care organisations, which are being trialled quite extensively in the US and some also in Europe and the UK and some in Asia and even New Zealand. We can see that again, the incentive structure change. And here you can see that bundled payments and accountable care organisations have the potential to incentivize an increase in quality, decrease unit costs, increase patient volume if that's what you want. And it really depends on how you structure those bundle payments. But per patient service volume, you can also incentivize that reduction. And really, these models, the bundle payments and accountable care, they work in a similar way in that there are a group of providers that get together. They have a contractual agreement to deliver a care pathway. And typically what happens is if that care pathway is delivered at a cost less than what would have typically costed under a fee-for-service model, for example, then those participating providers get to share in that cost savings, and that's effectively their incentive to, deliver best value care, deliver care that's going to improve our outcomes, which potentially means a reduction in healthcare system costs and savings or financial rewards to them. Now, there's a question over whether value-based payments work. And so if you really look at the literature, the jury is still out. So some of the literature suggests that pay-for-performance models have a modest impact on outcomes. And of those models, effects are somewhat small and dissipate over a few years. One study has reported on 1,302 outcome measures across 44 schemes and found around a half had a positive and significant outcome. Now, some people may say, okay, well, that suggests that these payment models aren't effective, but really what we're saying here is that nearly 50% of them are effective. And so there is a capacity to create effective payment models. Bundle payments, similarly, potentially effective in containing health expenditure, but the literature to date suggests that they mostly only preserve health outcomes. So they haven't been a big driver of improved outcomes as of yet. And similarly, accountable care organisations have experienced small improvements in quality and patient experience scores, along with small savings, but no huge impacts on patient outcomes. Now, as I've suggested, that doesn't suggest that we should dump these models. There is a significant investment, at least in the US, happening. They've received, CMMI, which is an agency that's been tasked with developing bundle payments and ACOs and other funding models, was given $10 billion by the government to develop these models between 2010 and 2020. And now they've been given another $10 billion to continue that development until 2030. And the idea is that all people that are funded by Medicare and Medicaid will be funded under some sort of value-based payment model by 2030. Okay, so how do value-based payment models operate? Well, effectively, they operate by assuming that any change in financial incentive will change provider and clinician behaviour. And that really means allocating greater financial risk from the payer to the provider. That's the crux of a value-based payment model. And that has obviously some implications for providers, whether they want to participate and how they can participate, whether they're actually able to manage financial risks. Of course, when you shift financial risk, you potentially need to change business models and care models. And so moving towards a value-based payment model may also impact strategic risk and operational risk, and also clinical risk as you try to change models towards generating improved outcomes. Here is a schematic that really just shows the trade-off between risk and reward. Down in the bottom left-hand corner, you have cost reimbursement, which is probably the lowest financial reward, but also the lowest provider financial risk. Similarly, you go up the scale in non-value-based payments, so historical block funding, fee-for-service and activity-based funding. And then you move into that sort of value-based domain, which is, pay for performance, capitation models, which the three I mentioned prior, bundle payment models, and two I have represented here, which is a bundle payment, which is just shared savings, or a bundle payment, which includes shared savings, but also a downside risk, i.e. if your bundle payment of services costs more than what would have occurred under fee-for-service, then you may need to pay some money back. And then accountable care organisations. I mean, the point here is that as we move up the provider financial risk then providers are going to require greater financial reward to cover off that financial risk. And they're going to require changing the way that they operate, and they may need help in that transition process towards managing that financial risk. Now, financial risk in itself will be derived from several sources, whether the model focuses on a specific condition or general health. And that really comes down to being able to assess patient risk. It's potentially easier to assess one condition versus the general health of an individual. Risk will also be determined by whether it's enrolled persons you're looking after or a general population, the complexity in the care pathway, the number of providers in the bundle or the accountable care organisation. So you can imagine that working with 3 or 4 providers is potentially much less risky than working with 7 or 8 providers, because you don't have control over what other providers do within that care pathway. Length of care episode may also increase risk. So the longer the care episode, the greater the risk, because you're exposed to more greater patient outcome variation. The size of the patient cohort. So if you've only got a small number of patients, you could be impacted by an outlier of one patient, for example, that may stay in hospital for whatever reason for 100 days, when in actual fact, on average, that person may be expected to stay for 5. And also the length of the contract. So length of the contract can provide some certainty to providers, but if it doesn't account for things like changes in potential technology or changes in inflation, for example, then the reward that's allocated within that bundle payment may be diminished as those costs of production, i.e. technology and consumables, increases, if that's not captured within the contract itself. There'll also be opportunities for providers in value-based funding models. So the opportunity to capture market share by offering better quality services, participating upfront in incentives to help transition towards an outcomes-based funding model. That may help better cover the marginal costs to improve quality, but also those investment costs that are required, i.e. improvement in data infrastructure and improvement in information technology. There are some potential issues. So providers are different, and payers may have little understanding of provider costs and risk appetite. So if we look at public hospitals, for example, there's lots of cost data on public hospitals, but there is a lot less cost data on GPs. And if a provider doesn't have, if a payer doesn't have good cost data, then it's very difficult to set an appropriate payment structure. Some providers may struggle to assess future patient healthcare needs or potential expenditure, which then means it's difficult for them to assess their risk as they move into a value-based payment model. And of course, there's other social determinants of health that may impact outcomes that providers may need to consider, but they may not have the appropriate data to do that. There's also the potential that a provider may be naive walking into a value-based payment model, but not really understanding the risk that's associated with their patient cohort. Now, they also may be less enrolment in a new model of care than anticipated, and that obviously has impacts in terms of managing risks. I've mentioned potential outliers associated with individual patients. There could be a potential lack of trust from an older cohort. So an evaluation that we did of a program within the Central Coast Local Health District suggests that older cohorts, in particular those with chronic conditions, were wary of moving into a new model of care, particularly from a private provider, because effectively they were just called up and asked to join. Patients may be older and more complex than originally thought, and there's some issues in accessing data before deciding to move into a value-based payments model. So access to data may be constrained, for example, due to privacy concerns, which may limit a provider's capacity to understand the true risk of participating in a value-based payments model. Of course, providers also need to understand their costs. There's going to be lots of upfront costs, so investing in new relationships, particularly in bundled payments and accountable care organisations, new IT, new billing practices, new models of care, training and education, not only for clinicians, but also for back office staff, new billing practices, and the investment required for cultural change towards generating value or improving value as well required. As I've mentioned, long-term contracts help providers recoup upfront investment costs, but that can make estimating future costs difficult. Those unanticipated cost increases can squeeze budgets or put pressure on providers to increase co-payments, potentially leading, obviously, to more payments from patients. There's obviously impacts from value-based payments on cash flows as well, whether it's a prospective versus retrospective payment. And there may be additional cash flow requirements to accommodate upfront costs. And the other issues are really around measuring outcomes. So within a value-based payment model, you really want to understand how care is being delivered and how that is attributable to outcomes. And we know that there is obviously other factors that impact outcomes that are not related to healthcare use. So here we can see that, the initial health status, for example, the social environment that an individual lives or works within, whether they're receiving informal care from family and friends, for example, or formal care maybe through the NDIS or through aged care programs, and their health-related behaviours. These all impact health outcomes. And even if you are delivering the best clinical care, you're probably going to get differences in outcomes associated with that based on those characteristics and those behaviours of individuals. And there's also going to be some sort of systemic and random error potentially in there as well. There's also the issue around attributing provider action to quality indicators. So just choosing the right quality indicator is going to be important. There's various errors that can make it difficult to attribute provider action to that quality indicator. So random errors, systematic errors, confounding, i.e. you don't have enough data to pick up on those other factors that impact outcomes that are out of the control of a provider. The locus of control. So, where do you sit in the care pathway and how can you impact that outcome can really impact this attribution between an action of a provider and the quality indicator. Okay, so having said all that, there is a pathway towards value-based payments, but it does need to address some of those issues that have been mentioned. The first one is motivating providers, and in the US, most of them have been voluntary, and so some of the models in the US really haven't benefited from having a good mix of providers within the program. Some of the issues around participation is that providers have difficulty in understanding the potential financial risk. They haven't had the resources for upfront changes. And there's also been disagreements between payers and providers on what is an appropriate bundle of services. The issue with voluntary participation, it can lead to self-selection and bias and limit savings. But if we are going down that pathway, then a funding model should at least encourage value-based payment models and discourage fee-for-service. Having said that, there obviously needs to be a supportive structure around that to ensure that when providers do consider a value-based payment model, they're getting, for example, the opportunity to participate in a reward that covers the upfront investment costs if it's not delivered by a grant through government, or to cover the marginal cost of changing their clinical processes. One paper in the US suggests that it's better to implement a value-based payment model with mandatory participation because you get a much greater mix of providers within that program, and you can then evaluate better how that program will work if it's rolled out to all providers. Importantly, a value-based payment model must align with broader healthcare system objectives. And the paper that I've written, it has quite a detailed table on some implementation steps that should be undertaken for a value-based payment model. Just to summarise, though, here, there has to be shared purpose among government providers and patients. So really, everyone has to be on board with this, and people have to, and providers have to understand that the status quo really isn't sustainable if we're going to deliver the type of integrated and coordinated care that that patients demand and prefer, and that we also believe is best for health outcomes, particularly for chronic conditions. There's going to have to be a lot of stakeholder engagement with providers, patients, among government to nut out some of the details. And really, there's going to have to be a choice as to where do we start with value-based payments. Which area do we start with? Something that's relatively simple, which is potentially something that has well-defined outcomes that you can attribute care to pretty easily, or do we go down some other pathway? And I would suggest that we start off with something somewhat simple, demonstrate success, and then build from that. There's got to be a willingness to change business and clinical models within providers. There's got to be support to cover transitions between fee-for-service and outcome and value-based payments. A strong executive and clinical leadership at all levels of government, but also within providers as well. And a strong evaluation and learning culture. And really, implementation is not a 1 or 2 year process. It's a 10-year to 20-year process whereby we implement models, we evaluate those models transparently, we discuss the results, and then we iteratively build on what we've learnt over time. So recommendations that have come out of the research that I've done, and there's 4 of them. One is to develop a cohesive national vision and ambitious national plan for value-based payment integration. That's because we really need to get everyone on board. We really need to allow providers to understand what will be happening over the next 10 years, for example, and allowing them time to prepare for that. I think in the past, what we've done is we've taken a sort of piecemeal approach to payment reform. We've introduced a couple of pilots here or there, but it really hasn't been a national approach at all. It's potentially caught providers off guard. And some of the pilots haven't really run long enough. And I believe that these pilots should be running for 5 years, because the first 2 years is really about learning how to change and to adapt within a new funding environment. We do need, I think, to trial and implement value-based payment models nationally. At the moment, reforms would suggest that payment reform will be done on a state-by-state basis, and even by a PHN, LHN basis. I think that's potential for duplication and an inefficient way of seeking funding reform. One of the benefits of a national reform approach is that you can implement the same model over different states. Excuse me. Understanding how it impacts different groups better. The second recommendation is around creating an independent national payment authority. And that, first and foremost, is really to allocate clear responsibility for value-based payments models across Australia. Having said that, there is huge benefits to having a national payment authority for coordinating and designing funding model implementations and evaluation. Obviously seeking quite a lot of input from all governments, state, federal, territory, from PHNs and LHNs. But having an independent national payment authority can also better advocate for funding model needs and policy discussions. And if the government didn't want another independent authority, then there's potential for organisations like IHACPA to step in, although I'll let Keith talk to that. The third recommendation is improving data collection, analysis and access. So we do need to get the outcome and cost measurements right. If we don't prepare for that, if we don't test our outcome measures, our cost measurements, if we don't test our risk stratification, we get that wrong, then we're really going to lose momentum at the start of this process. So there needs to be a lot of investment in getting those right. And that requires better data collection, not only from the healthcare system, but also from other sectors that impact health outcomes. And more investment in collection analysis and reporting and sharing of data between providers and also between government, because that's going to be required to ensure that we have good information to make decisions. Excuse me. And finally, the last recommendation is investing in provider education, training and innovation, developing standardised tools to measure patient health risks, high quality clinical guidelines, identification of best practice care and sharing that best practice, and training programs to help providers change business models, but also peer-to-peer learning platforms. And in the US, that has been shown to be helpful in adapting to new models of care and also building bundle payments models. So I think I'm on time. That's it for me, and I'll stop sharing.
Thanks for a fabulous presentation, Henry. Before we move on to hear from Keith, I do have a question to you about health economists. In the lead up to today's webinar, we had quite a bit of feedback questioning why we actually need to listen to health economists. So why do we need to listen to health economists?
Well, you know, we obviously have a specific skill set in that we spend our time looking at the way the healthcare system is funded and financed. And, you know, I would say that what I'm showing here is really not my opinions. It's more what the literature is saying internationally. And, you know, there's been a lot of research in this area around value-based payments that have been undertaken by individuals in the US and the UK, and not only health economists that are looking at this issue as well, it's also clinicians in the US. They understand that they need to move towards more value-based payments. So, you know, I suppose this is our bread and butter, and we do have a lot of research to back up most of what we say.
Thanks, Henry. Keith, we'd love to hear from you now.
On that particular topic, or
no, just
is it okay?
Yeah.
So I've prepared some slides, so I'll go straight into that if you like. So, but just to pick up on the question and Henry's response. So, as you would entirely expect as a card-carrying health economist, you would expect me to say that funding matters, and you know, that is our, as Henry said, that is our skill set. And we think that funding matters, and we've got empirical evidence of this. You know, the phone has been around for about 150 years, but it wasn't until a couple of years ago when telehealth came onto the NBS because of the COVID pandemic, did we actually start using the telephone. Government in out-of-hours space, you know, just a few years ago, all of a sudden, you know, the government became generous through an NBS items for out-of-hour care, and you know, there was a little while where it was hard to distinguish between Uber pizza deliveries and GPs going across the streets. So, you know, funding really matters and can have an incredibly big bearing on how healthcare is delivered. So when then it comes to the sort of research that Henry was pointing out about, you know, we've done payment reform and we've looked at it, and then lo and behold, we're not really seeing much change, or, you know, as Henry pointed out, only 50% of the time we've seen change, and you know, a lot of the times we see a little bit of movement in cost, but not much on outcomes. Us as health economists sort of scratch our head and go, oh, why is this happening? Why is it not as successful as we kind of think it should be? And also knowing how important funding can be. So I think it's kind of important to sort of think, I hope you can see the change in the slide, that payment reform is really, it's part of the policymakers' toolkit. It's not everything. So I think one of the things that we need to start thinking about a little bit more is what's the problem? What's the clinical problem that we're trying to fix in the first instance? You know, is there evidence of suboptimal health system performance, as Henry pointed out, something that people are not using the guidelines, or care could be more efficient or more equitable, or deliver better outcomes? Then if the answer to that is there is some evidence of that, then the second question is well, is payment systems actually the driver of the problem? Because it may not always be payment system. And then if the answer to that is yes, then let's have a look and seeing if payment reform may be beneficial. And I still put may be beneficial there, because it may not be the only option that is available to try and address the problem. After all, you know, I think health economists in this instance do need to sort of be reflective and put the same criteria and rigor on payment reform interventions as we do on any other type of intervention. So, you know, yes, does payment for value or value payment system work? Well, yes, maybe it does, but that's not the only question we should ask. It's also the question about whether the amount of money that we're paying on payments is actually delivering better outcomes in comparison to other ways of trying to change behavior and improve the system. The other aspect of this is that it's almost a small miracle when we actually do implement reform and put payment reform into place, because of enormous multidimensional problem that it's trying to address. So payment reform, particularly around integrated care or bundled payments, is about trying to bring together the fragmentation. So here in this country, as well as most overseas countries, we tend to establish the institution first and then find a way to pay for it. So hospitals were built, and then we find a way of paying for it. Then primary care GPs were there, or doctors were paying, we find a way to pay for it. And of course, because of that, we get fragmentation, not only in the isolation of each of these sectors, but also in the way that these sectors are paid for and are funded from all different types of payers. So that's essentially one of the challenges that payment reforms try to actually break down, and that is to not only bring the fragmentation of all the care sectors, but also the fragmentation around the governance and around the financing sources and who takes responsibility. So that it's a multidimensional problem that payment reform is trying to address. Then, and I think Henry has already touched on this. One of the challenges is that we have lots of pilots, we have lots of innovation that is happening. One of the big challenges is then to turn that from local to global. Another challenge that we face here is around workforce. So every time we have a payment reform, particularly around integrated care, there is a workforce change need. And it's not always clear that workforce the needs can be met by the capacity that we have. And that's just not just in the numbers, because it's a very tight labor market at the moment, but it's also in the type of skills that people have. And then the last aspect of fragmentation is research and policy. And I think that there is in this country, there's a lot that can be gained by greater integration of research and policy. And that's particularly true, I think, in sort of not just in the evaluation of payment reform, but also very much in the design of payment reform. And it goes back to what I was saying before, is what is the problem that we're trying to address? Is payment reform a potential answer to this problem, and what would that look like? So almost starting from the end, starting from where you want to be, and work backwards in terms of what it is that we want this market to look like, and how would you then pay for this? So there's lots of work to be done as policymakers and as researchers to understand that. One of the frustrations, I think, of many policymakers and researchers and observers in this space is that we still really don't have a good sense of what payments, what alternative payment systems are. We call something bundled payment and we think we know what that means. But really, there are 1,000 different myriads of a bundled payment system or mechanisms. And then the context within which you place that bundled payment system also has 1,000 different mechanisms by which you can operate and change. And the healthcare homes example is a really good example of the different types of mechanisms that are at play and the context within which that payment reform was put into place. So there's lots more work to be done to understand payment reform. What's the intervention before we can say anything concrete about what works and what doesn't work. And I'll leave it at that.
Thank you, Kees. I look forward to hearing from you in the discussion part of today's program. Michael, we'd love to hear from you now.
Thanks, Rebecca. Thanks so much. Hi, everyone. I will admit to also being a card-carrying health economist, but what I'm going to do here today is talk about value-based care coming from my work as a clinician. So I've been a GP for over 20 years and worked in the UK as a GP. And so I've got this experience of working within these payment models as well as researching them. I like to say, sort of coming from a clinician background, we kind of like to think that we're doing a good job. We know that Australia has a high-performing health system providing world-class health outcomes pretty efficiently compared to OECD spending. So we kind of come up with a baseline that's not starting too badly. So I think one of the issues for the value-based agenda is often clinicians can be a bit suspicious of it because although Henry points out that Porter and Teesberg talk about outcomes that matter to patients, often it feels like they're funder-driven outcomes and the needs of patients and clinicians are less important. And I think, not surprisingly, clinicians are often resistant to that, and particularly when they see funding going to elsewhere in the system when they feel it should be where they are seeing the patient on that day. I think Henry's already alluded to, there are particular problems with valuing primary care. So how do you clearly define an outcome that you might want to value within a value-based system? And obviously this is a challenge because primary care provides long-term holistic care, looking at multiple problems. It's relatively undifferentiated. Disease progression is often slow. It's often difficult to attribute effort to any particular element of care because there's lifestyle factors and social settings as well. So what we get left with is it's difficult to find an outcome measure which is specific enough to be attributed and valued, while also broad enough to be relevant and accepted by providers as something that they do. And the other issue with primary care is often care involves observation rather than active intervention. So it's difficult to value the absence of a stroke from having someone's blood pressure monitored well for 20 years than it is to value the cost of having a stroke. And so that's one of the challenges we face. The second challenge, and I think Henry's also alluded to this, is the shift of risk. So one of the features of alternative payment models is that they shift the risk from the funder towards providers. And that risk is varied depending on size and potentially means that practices which are larger with economies of scale are more likely to adapt to innovation and also the opportunities of value-based care. And what we have to work out is that in the long-term interest of our patients. So if smaller practices are non-viable because of the considerations of value-based care, that might lead to worse health outcomes and less preference-based care than what patients currently receive. So it's sort of another word of caution. The third area where primary care is struggles in this area is actually having evidence. We know that relatively small amounts of research funding of the research pot go towards investigating primary care and evaluating its outcomes, along with health services research more generally. And that means it's quite difficult for primary healthcare to prove the value of its baseline care, let alone showing if it improves. But having said all that, I think we'd like to get better health outcomes. And if we can do it more efficiently, then that would be great. And there are a couple of things that we could do differently to do that. So Henry's already alluded, as has Kees, the importance of working with providers and patients to design measures and outcomes that are of value to patients. And particularly, we do know things that work. We do know that doctor-patient continuity of care is improved with better health outcomes. We do know that having appointments within a week of a patient being discharged from hospital with a GP is improved with associated with decreased risk of hospitalisation, or improved after-hours care, or improved comprehensiveness of care, or even increased consultation times. And some of these could actually be introduced with alternative fee-for-service models, as well as needing the use of the alternative business models. Henry's also alluded that the alternative funding models and the value-based care creates a need for considerable infrastructure for monitoring so that you can evaluate what's been happening, and that is going to increase costs considerably, and there's a question of where in the health system is that going to come from. In the area of bundled payments, I think one of the potential areas where these models can work is with the potential that we'd be able to bundle multiple sources of funds, and potentially this could be a role for primary health networks. And it's one of the proposals within the recently released Strengthening Medicare Task Force report. So where you might pull funding from the federal government, from state and territory jurisdictions, and potentially from other funders. And by doing that, you might reduce the risk for individual providers for participating in an initiative, and also create greater capacity for them to be involved in these initiatives. So I think the take-home message is the jury's out on these value-based cares, particularly in primary care, but we do need more research to look at, try and understand, can they be implemented, how they're well implemented, and to make sure that they improve health outcomes for our patients. And I'll leave it there.
Thank you, Michael. Kees and Henry, would you like to join us for a bit of a discussion?
Love to.
Kees, you mentioned, you talked about fragmented care and a fragmented system. I want to just touch on the idea of financial interdependencies. So current funding models don't really incentivise good integrated care models, and they've led to a little bit of change paralysis. So if we were to reform towards a value-based payment model, what do you see as some of the hidden financial interdependencies that we need to be cognizant on? So, for example, the concern that lowering payments for some services could actually impact on the ability to fund other services. And Michael and Henry, I'd love to hear from you on this as well.
Sure, yeah. So I think that is one of the challenges. If you have a fragmented financing system with different payers being responsible for their little domain, you create incentives for those payers to just look after what they worry about. And that, of course, is the best examples of that, which has been around for decades, for as long as I remember, is the cost shifting argument. Now, cost shifting is in and of itself is actually not an issue. You and I are the taxpayers and we pay for it, and whether that tax goes to the state, to the federal or local, it doesn't really matter. We don't care, but our government agents care because it is their little bucket. The only time where it does actually matter is if that cost shifting leads to some kind of inefficiency, where there's duplication in the system, or where because of those responsibilities, it stops people from working together to provide integrated care. Now, I think that under the National Health Reform Agreement, there are opportunities to at least get the states and the federal, Commonwealth government together to look at this collectively. And so, yes, under the NHRA, there are provisions and certainly I suppose an indication and a strong motive to try and come up with alternative funding models that can bring together not just what happens within a hospital, but what happens outside of a hospital, whether that's actually non-admitted patient services or even primary care for that to happen. So there are mechanisms in play to try and do that. So there are some examples of that already in play, but I think from IACPA's perspective, we look forward to working with all the jurisdictions to expand that role.
Thanks. Henry?
Yeah, so I mean, I suppose, I agree with what Keith has said, but just to expand that a little bit, not only looking at the healthcare system, but outside the healthcare system and the funding models that are associated with delivering services that impact health outcomes. I mean, if we're talking about hospitals and we're talking about something that's really specifically defined, so a knee replacement, for example, then it's somewhat easier to develop a payment model that can effectively deliver a pathway of care, because that pathway of care is really easily defined. The issue is when you're looking at things like mental health, for example, whereby the pathway of care is really difficult to define. It's going to be extremely heterogeneous for individuals with different characteristics, different living circumstances, and where things like housing, education, justice will impact health outcomes. And I think the real challenge for these funding models, value-based payment funding models, is moving down that pathway and bringing these other non-health sectors into the funding mix, because that means that we don't not only have to reform healthcare funding, but potentially funding from other sectors and attribute outcomes to other sectors as well.
I couldn't agree more with what Henry said, that I do think it involves this sort of, whether it's risk adjustment or but considering these other costs which are beyond the direct health costs that often aren't put in these models, and we need to do a lot of work to try and include them.
Fantastic. Michael, you just mentioned risk. Do you think that the COVID pandemic has actually influenced how we as a system view risk? And do you think this has influenced payer-provider willingness to adopt new funding models?
Look, I think what the experience through the pandemic has been, so particularly for clinicians and so obviously for primary care, is there was a lot of rapidly changing policy, a lot of changing innovations. I'd say many practices went into the pandemic with this goodwill of saying, particularly with the vaccine rollout, we've got to be part of that. But the experience of many practices is that involvement in that has not been good. It hasn't been financially good. It's been very stressful for practices. And there's a lot of, I would say, burnout or change fatigue amongst clinicians. And so I think that's another real challenge for any more proposed reform, is that there needs to be a lot of change management support, because I think that whether you call it goodwill or willingness that clinicians have for changing the system may not be as strong as it was before the pandemic.
Keith, would you like to comment?
Yeah, look, I think we've gone backwards a little bit. So I think with one of the greatest things, I think, Michael, biggest things, I should say, not greatest, biggest things that happened in the COVID policy response was the telehealth, the rollout of the telehealth aspect. And that in one sense was a recognition of value, because all of a sudden a telehealth consultation became more valuable. Because it stopped people from having to go and be exposed to risk and getting COVID whilst traveling to and from and being sitting in the waiting room. Now that now we're no longer in COVID, some of that value may have dropped off, but that doesn't mean that telehealth is without value. And so I think that's the next challenge. Is how to recognise that value and still maintain the risk appetite for government to fund services like that.
Henry, would you like to add anything?
Yeah, look, I'll just add something from the government perspective. So, one of the things that I noticed through that COVID pandemic was, first of all, allowing telehealth to occur didn't mean that the sky fell in. And I think governments, particularly the Treasury, have been really cautious in the past, giving additional access to individuals to greater levels of care, and what that would do to the budget, because obviously Medicare is an uncapped funding item. So I think hopefully the Treasury have taken notice to suggest that there isn't an unlimited amount of demand if you provide greater access to individuals. And that greater access can actually improve outcomes. And secondly, the willingness to adopt greater risk. Well, I suppose it wasn't willingness because they just had to, for changing care models. So the government allowing providers to change those care models without going down that process of, 5 years of thinking about it as to whether it's a good thing or not, just getting along with the job. One of the things that I hope will be a legacy from this COVID is a greater willingness for government to take a little bit more risk in its reform, both through funding, but also through asking providers to change their models of care, because I think in the past that's held reform back.
So if we switch to the consumer side of the equation, value-based payments open up an opportunity to provide care quite differently to what people currently know. We've got lots of new digital technologies, remote monitoring, care outside of hospitals. How important is it to bring Australians along this journey, and who's responsible for this? Michael, can I get you to comment?
Yeah, it's a really good question, Rebecca, because I think it's often not considered, like I was talking in my initial introduction, is that a lot of the discussions we talk about value to funders more than values to consumers. I think it's difficult too, because often what the value to consumers, it's often simplified to access, and often the balance between access and quality and safety, all of them aren't looked at together. And I think we do need to have it's important that we get patient input and consumer input to say, what do you want? But also understand patient preferences. What are people willing to pay? Like if you say to people, do you want better access? The answer is yes. But there's a lot of research showing, what patients would prefer in terms of time to wait or cost for an appointment. And we need to consider those preferences more fully in designing these programs.
Henry?
Yeah, look, I think this is a great opportunity if we were to move down this sort of value-based payments model to think about new models of care that really do meet the preferences of individuals. And, some people may disagree with me, but I personally think that the fee-for-service model that we currently have has really driven a particular type of care. And obviously it doesn't fund that sort of integration activity well. And so people haven't been integrated in their care pathways. There is opportunity to innovate within value-based payments models, which potentially isn't there currently, particularly if the government really wants to push innovation. They can drive that from an incentive perspective. But in terms of bringing patients along, I think that's the responsibility of everyone. I think it's the responsibility of government, and I think it's the responsibility of providers. That everyone needs to be on the same page. Everyone needs to realise that the pathway that we're currently going down with our antiquated funding models isn't going to meet the needs of patients, particularly those with multiple chronic conditions in the future. And indeed, it's not meeting the needs now. So, I think there's a strong argument to ensure that we can get providers and patients aligned with government.
And Keith, your thoughts?
Yeah, so I agree. In the fee-for-service system, you get what you pay for, and the closely aligned statement to that is you don't get what you don't pay for. And so what in that system, it's always the relationship between the patient and the provider. But the provider is unable to provide the full menu of options and preferences and align to the preferences because it's not being funded. And so that is where payment reform can come into its own, because it allows greater payment systems that allow greater flexibility in terms of what the provider can offer to align it to what the patient wants within their episode of care, is a really strong aspect or a strong motivation for payment reform.
Keith, I might stay with you for the next question. How critical is regulation to value-based healthcare and value-based payment models?
Well, it's everywhere, isn't it? It's all pervasive. I mean, working at IACPA, we do things to the letter of the law, what we are allowed to do and what we're not allowed to do. So, yeah, it's all around us, and to where the regulation becomes problematic if it stifles innovation, if it stifles people from exactly what I was saying before, if it stifles providers from offering the care that they want to provide, that they think their patients want to provide. And so that's all I can say about regulation. I'll let Henry and Michael take that one too.
Well, Michael, I might pass over to you and hear what the primary care point of view is.
Look, Keys has said it exactly. Like, I think what we need to make sure is that the regulations support innovation and don't stymie it. And maybe that's one of the things we noticed in, like, telehealth was amazing in offering this flexibility in providing care that previously had to be provided face-to-face. But then there was a lot of comment about the way the vaccine rollout was delivered, that it was very inflexible about who could give the vaccine, who had to staff it, how you had to manage it. And that meant that the capacity for general practices to innovate in delivering those vaccine clinics quickly was probably a lot less than, say, in a state health run clinic where the regulations allowed substitution.
Henry, do you want to add anything?
Yeah, so, first and foremost, obviously, is to ensure safety and quality is continued to be delivered. And so regulation needs to be in place, remain in place to ensure that occurs. But one thing that will need to happen is there will need to be a change in legislation and potential regulation associated with moving towards a value-based payments model, because there are barriers to value-based payment healthcare at the moment, particularly around access to data. And so one of the first activities that have been listed as that accompanies the addendum towards value-based payments is to review the legislation to ensure that legislation that imposes barriers to value-based healthcare, access to data, sharing data, privacy, all the rest of it is removed in obviously an effective and safe way to allow the functioning of a value-based payment model to operate.
Thanks, Henry. You've actually led me beautifully onto my next question, which is around data availability. Michael, how is the lack of data availability, particularly in primary care, impacting on reform? And what do you think can be done to help improve this?
Look, I think for a long time, practices have had their own little electronic health records in the practice where we are able to share all the information between our patients attending that practice. But the information sharing beyond that has been minimal at best. So we've had My Health Record, but for many, it doesn't integrate with your electronic health record. It has to be curated. So for clinicians, it's actually something that adds to your workflow, doesn't actually help it. And then we can't access any of the data from state health facilities that would allow us to understand, what had happened to our patients and so it means that we rely on faxes, and not by choice. It's just that's often the only way we get that information. So I think the lack of sharing of data across the system, and I think the lack of obligation to share information about health interactions is a real problem.
Keith, would you like to add to that?
Yeah, look, I totally agree with Michael, but I think I see that as the next frontier, and I think we do have to recognise that there's been enormous progress in this area over the last 20 years. I'm a lot older than Michael, so I've seen the changes. Back 20 years ago, data linkage was a dream that we looked at jealously in Canada and Oxford and others. Now it's a reality in this country. But I totally agree with Michael that the next frontier, particularly in primary care, which is still a black box, we We know how much is spent on it. We know the utilization, but that's about it. You know, we still need a lot to know, need to be able to work out what people are being treated for, what are they coming in for, what are being treated for, and then being able to link that across their episode of care, which of course spans other sectors, including aged care, dare I say, and acute care.
Henry?
Yeah, look, I mean, I note in my report that the pathway to value-based payments is a digital pathway, because really, if we're going to implement a scalable level value-based payments, then we really need better data, better IT, better sharing, better standardization of data, because that's the only way that providers are going to be able to understand risk. That's the only way payers are going to be able to understand how much they should be paying providers and how to create incentive structures. And I think, you know, there's data out there that we can work off already. So, for example, in public hospitals, there's good cost data. As I've mentioned before, outcome data is not so great, particularly if you're talking about value-based care, i.e. the outcomes that matter to patients. But as we sort of move out of hospitals into sort of general practice and community, the data is a lot less clear or usable for value-based payments. And so we really need to invest a lot in that data infrastructure to embed value-based payments within the healthcare system.
I want to start thinking about the pace of reform. Has there been any issues that have surprised you that have actually really slowed down the pace of reform? Henry, what do you think?
The pace of funding reform?
Yeah.
I'm not really surprised that it takes a while for funding reform to occur, although, you know, 1984, it's a long time since we've had any sort of systematic change to funding reform. There has been obviously tweaks along the way in terms of incentivizing bulk billing, for example, and the relationships with private health insurance, particularly funding private health insurance. But if we look at, you know, the history of Medicare, for example, and even prior to Medicare, the history of healthcare funding, I mean, that's always been at the front of the political agenda. And as I've mentioned, the Whitlam government introduced Medibank initially, and that was effectively dismantled after he was kicked out of office for the next 5 to 6 years. But there was also a lot of change. And if you look at that, there's always been argy-bargy between the governments wanting to make wholesale change to systems and providers who have embedded their care models and business models in the current system. And I can understand why it's very difficult for change to occur. But I mean, I suppose that's why I think we need that vision and we need that 10-year plan, because I don't think it's going to happen if we continue down this pathway of just trying to create these pilots here and there. It needs more investment. It needs to bring everyone along.
Michael, I'd love to hear from you.
Yeah, Rebecca, look, I do think it's the thing that has continued to surprise me is that we have kept doing short-term pilots, and then the short-term pilots, particularly in primary care, haven't proven any long-term savings. They've actually increased cost in most of them, and therefore people go, oh, well, that didn't work. Now, and then we fed back and said, no, you need to run these more long-term. But that's been the result from the coordinated care trial, from the diabetes care pilot, even the healthcare home trial. But the point being that we need to embed this as a long-term analysis and evaluation of these interventions and not expect some short-term result of either cost savings or necessarily health outcomes.
Keith, your thoughts?
Yeah, no, I agree with both what Henry and Michael were saying. And I do think that not thinking about this strategically and having all these little trials along the way, and, you know, well, shall I call them failures? No, not as successful as we thought they would be. It kills the impetus and kills the motivation for any leader and policymaker to try and do something. So thinking about this more schematically and as part of the whole reform agenda, where we expect to not always have the successes that we want, but that's part of the learning process that we want to do. But it does also come back to sort of the point I was trying to make earlier, which is we don't spend enough time on the design of these reforms and the contextualization of the problem that we're trying to solve. And so we go out and it's trial and error, and then we do it all again without thinking about the errors much again.
Fantastic. So that brings us to the end of our formal part of the discussion. I'd like to throw a few questions at you from our audience. So can any of these funding models adequately address equity of access to healthcare services? Medicare fee-for-service seems to be widening the gap over time for low and income and rural patients. Michael, would you like to comment?
Look, I think there's definitely a problem in that as Medicare gaps increase, as the funding that supports bulk billing has not kept pace with inflation, that out-of-pocket costs have increased. I think the bulk billing incentive has been a great bulk billing incentive for people who are healthcare cards or children under 16 has been a great initiative to support bulk billing and for groups, disadvantaged groups. So I think that's an example where it has worked. I think some of the work that the PHNs do in commission services for underserved populations, like people with homelessness, people living with homelessness or Aboriginal and Torres Strait Islanders people, I think there are other important ways where we can get resources and services to those populations, which I can't say that it creates it completely equitable, but hopefully goes some way to sort of reducing the inequity.
Henry, would you like to comment on that?
Yeah, so I mean, obviously equity is a huge consideration in the way that funding is allocated, and you know, Australian society has been very upfront in that. Each time we've tried to introduce co-payments, i.e. Bob Hawke tried to introduce them in, I think, 1993, they were dismantled by Paul Keating, and then Tony Abbott tried to introduce them, I think, in 2014. There's been a huge backlash from Australian society because we believe that we should have access to care when we need it, regardless of the income that you earn. In equity in value-based payments, it's a great question, whoever asked that, because there's been an evaluation of the last 10 years within the US on what they call alternative-based payments. And one of the issues that came out of that was that these value-based payments really haven't focused on equity. They've been focusing on efficiency and trying to improve outcomes. And that is now starting to change. So if you look at the CMMI strategic intent for the next 10 years, there's going to be a lot more focus on creating value-based funding models that do try to improve equity and access to care.
And Keith?
Yeah, so equity and access are a multi-dimensional problem. So access is not just about the co-payment that you face. It's not just about the co-payment, it's about the affordability, the income that people have. So that's a two-dimensional problem. It's also about the physical access that people have. And it's about having access to culturally appropriate. So it's multi-dimensional issue. And we need to think about where does funding and payment systems play into that. Now, obviously it has a role in thinking about what's the right price for services. And at the moment, as Michael sort of mentioned, we use a concession card as a bit of an indicator of who can afford what, but it's an incredibly poor proxy for what people can afford. You know, it's very hard to not have a concession card if you're over 67, and it's very hard to have a concession card if you're under 67. You have to be on a really low income or be on an allowance. So it's a poor proxy for affordability. So there's a lot of reform that we can do around that. But then also the funding aspect and the payments can also support greater physical access as well as culturally appropriate services that we want to value. So it is not the end all and be all of access, but funding payments do play an important role.
Keith, I'll stay with you. Should we be prioritising developing and implementing value-based payment models for public hospitals in Australia?
Thank you for, have I got the IACPA sign behind me? No. Like, obviously, as Henry mentioned in his paper and presentation, so IACPA does include safety and quality now in its funding and its pricing model. So we have adjustments for hospital-acquired complications, for sentinel events, and avoidable hospital readmissions. They're just, well, they're still fairly early days on those. So that is one dimension, and it's really a safety dimension as such. And as I mentioned before, there is provisions for IACPA to play a role in future funding reform, which of course is about bringing greater value and greater patient-centered services to the fore, and trying to work with jurisdictions to deliver, or to create a funding model that works for those types of outcomes.
Thanks, Kees. I think we've got time for one more quick question. This is from Michael. Do you have any suggestions or experiences on how to measure avoided poor outcomes via prevention?
No, look, I think it's a bit like what I was trying to say before, in that it's harder to measure someone not having a stroke than it is to measure them having a stroke. So I think, there are proxy measures that you might use, but it's going to be long-term blood pressure over time, what medication, and it's still not going to be directly attributable, because you're going to have to treat 50 people like that to avoid one stroke. So as I said, for primary care, I think it's one of the real challenges of finding an outcome, a clinical outcome like that.
Great, thank you. So I think that draws a close to our program. I would like to thank our speakers for joining us today. Just quickly share my screen. A copy of the webinar will be made available to you all shortly, but to find out more about our future events, please head to the AHHA website. So again, thank you everyone for joining us, and I look forward to seeing you again at one of our upcoming events. Thank you.